Hello everyone, my name is Donna Gairns. I'm the National Nurse Director with Lymphoma Australia, and I'm joined today with Professor Con Tam from Peter MacCallum Cancer Centre and Royal Melbourne Hospital in Melbourne. Welcome, Con.
Thank you, Donna.
Thanks for joining us. Well, this week Lymphoma Australia and many other people in the haematology world were going to be in Europe for the European Hematology Association conference, but however, due to COVID, we are all back in our own countries, and but that hasn't stopped us from trying to get the updates from the various conferences. And it's been EHA, but there's also been the American Society of Clinical Oncology conference in America as well. So there's been a lot of conferences going on behind the scenes, which you presented at actually with this same study that we're going to be talking about. Yeah, thank you again for coming to speak to us. You were a lead on the Aspen study that was open to patients with Waldenstrom's disease. Now, this study did receive a lot of attention both at ASCO and EHA, where it was both presented. Can you talk to us a little bit about what that study was about and some of the results that came from that?
Sure. So the Aspen study is a study in Waldenstrom's macroglobulinemia. And included both patients who have relapsed after previous therapy, as well as a small number of patients who had never been treated for the Waldenstrom's, but were not eligible for chemotherapy for various reasons. And it's a comparison of two BTK inhibitors. So the established therapy was ibrutinib in the control arm, and the newcomer is zanubrutinib or BGB-3111. So patients were randomly assigned to getting one of the two arms, either ibrutinib or zanubrutinib, otherwise known as BGB-3111. And really, this came out of the studies that we did with zanubrutinib in phase 1, showing that zanubrutinib seemed to be very effective in Waldenstrom's, achieves very high drug levels, and seem to have a benign side effect profile. So the question is it really better than ibrutinib, which is why the Aspen study was conducted. So in total, we have about 200 patients, half received ibrutinib, half received zanubrutinib. And in the end, when we looked at the endpoint for better responses favoring zanubrutinib, and where we said we'll do the assessment, we actually didn't see what we call a statistically improved response rate for zanubrutinib. So zanubrutinib had a higher response rate, in particular, the number of patients with very deep responses, where there's been a 90% reduction in the Waldenstrom's disease, was about 28% for zanubrutinib compared to 19% on ibrutinib. But when we did the statistical test to see if that could have happened by chance or not, the test came back with a p-value, which is the number that we use to measure is this a real observation or could have happened by chance, of 0.09. So what that meant is that it looks like as if zanubrutinib is probably better, but we can't put our hand on our heart and say that it didn't happen by chance. So in other words, we go back to the conservative view that ibrutinib and zanubrutinib are equally as effective for Waldenstrom's. We didn't prove beyond doubt that zanubrutinib is more effective. But what we did see, though, was a very large difference in the side effect profile. So remembering that zanubrutinib is more targeted, so therefore is a cleaner drug and potentially has less side effects. And we saw a reduction in all the important side effects of ibrutinib, including diarrhea, swelling, muscle aches, and also in the number of patients who have high blood pressure and atrial fibrillation, which is where the heart goes out of rhythm. So specific to atrial fibrillation, the rates were 18% on ibrutinib and 3% on zanubrutinib. So it was the 6-fold difference in the atrial fibrillation rates. And this to me is a really exciting finding because prior to this, we had the sense that a cleaner drug like zanubrutinib would be associated with fewer side effects than ibrutinib, but we never were able to prove it. And now in a head-to-head study, where we compare the two drugs directly, we now see beyond doubt that there is a much improvement in side effect profile.
And that can be translated to other lymphoma subtypes too, yeah?
Correct. So I mean, there's no reason to think why the side effect profile that we saw in Waldenstrom's disease will not translate to, let's say, CLL or mantle cell or other diseases that ibrutinib is useful in.
Oh, that's fantastic. And what is the future direction with having these results from this study now? What is the future for
Sure.
studies?
So I think for us, the most important thing, although the response rate will not so large enough to say for sure there's no difference, you could not have happened by chance. I think what's really important to patients is how long they stay in remission for before they have to change to a different drug. So only time will tell. So we need to follow these patients up for longer to see how long the responses last for. We're hoping that the zanubrutinib, because it's better tolerated, are able to be taken for longer, and maybe it's more efficient. So therefore, the disease will be controlled for longer, and overall patients can stay on the drug for longer before they have to switch to another class of drugs. So I think that's further follow-up is required. There are also a number of studies to compare zanubrutinib versus ibrutinib in different diseases, such as CLL. And I think those studies will read out in the next few years to see if we can reproduce this sort of improved side effect profile type data. And then, of course, we're now combining zanubrutinib with drugs like venetoclax, just like ibrutinib with venetoclax, to see if we can get people into really deep responses so that when people go on these drugs, they're not stuck on these drugs for life.
Yeah, no, that sounds fantastic, especially with a group that A is rare, but also incurable as well. So having a better quality of life is very important for this patient group. No, that's fantastic. Thank you so much for your time today and providing us an update on your Aspen study, and all the best with the future, with your future studies.
Thanks, Donna.
Thank you.